Good afternoon, everybody, and thank you all for being here. My name is Bob Duff. I'm a state senator. I represent Norwalk and Darien. I'm in Hartford, and it's great to have everybody here in this room on a Friday when everybody could be doing something else, not sitting in traffic, and hopefully having a little bit of fun on a Friday afternoon. But
he works very hard for Norwalk Hospital in this community. I see him.
So we appreciate your all being here, and for the hospital for hosting. This is I also just want to, of course, welcome our Congressman Jim Himes, who's a fighter for us here in the 4th Congressional District, and I'll introduce him a little bit more in a second. But want to thank you all for coming to talk about the Affordable Care Act and healthcare in general, and how we can really partner and continue the conversation on this really such an important topic. As we know, healthcare continues to be a very, very important issue to all of our constituents. It doesn't matter what income strata you're in, but especially affects the poor and working families, self-employed, and it causes a tremendous amount of stress. And for most of us, we know, those of us who are legislators, we know that when you do a large piece of legislation, and especially the Affordable Care Act, when it takes such a large part of the economy, that it requires conversations, it requires some tweaks and some changes, and unfortunately we've not seen that because there's been some gridlock in DC, as we know. But I do think that continuing to have these conversations, working together, we can ensure that we meet the needs of all of our constituents. We've worked together to help to control costs, to make sure we have good patient experiences, and that we do creative and different things that had not been looked at before. So, for example, I think about the hospital's partnership with the Smilo Life Center down in South Norwalk. That is a new partnership that's happening. I think that's all very exciting, and that it really shows creativity on the part of the hospital and Open Door Shelter at the same time. So all those kinds of things, and I think make a real difference. And then you also see partnerships that Norwalk Hospital has with Memorial Sloan Kettering and others as well. So, and I can go on and on with the various different groups that are here, but I think it's more important to hear from all of you, and as we wait for our senator to come in, who I did serve with in the state legislature many years ago, and he's just had a meteoric rise. But one thing about Chris is that he has always talked about this issue in healthcare and the importance of healthcare for so many years. He's never ducked the issue whatsoever. And I would say the same for our congressman as well. Jim has always been a fighter for us, and not always taking on the easy answers or the ones that are the safest route. I think in leadership, it's important, especially these days. A lot of the answers that we have on things are not easy, and having somebody like Jim who thinks through things, works through things, and works and reaches across the aisle, works on a bipartisan basis is extremely important. So Jim continues to be hands-on to advocate for us here in our communities and to fight for the things that are very, very important. So with that, I'll hand it over to our congressman.
Thanks, Bob. And let me agree most fervently with what he said, which is I think the catalyst for this was Senator Murphy, whose career has been bound up in the healthcare system. But we're really here. It's a neat opportunity for us to learn, and therefore not to talk as much as maybe we're prone to do. So I just want to say this. Thank you for being part of this conversation. We're at an interesting moment. First of all, interesting crew, right? Because as you know, when it comes to things like Medicaid and the way people actually get their health care in a city like Norwalk, it is very much a shared responsibility, shared resources, shared oversight and jurisdictions between the state and the federal government. Medicaid in particular is that way. And so it's a great opportunity. I think we've got the majority leader in the House and 2 members of the Congress who are very, very focused on this. The second of whom has just arrived, Senator Murphy. Welcome. And we're just flipping the order. If that,
Go for it.
And so what's interesting for me, the 10 years I've been doing this really have been defined by the debate around healthcare. And 10 years ago, the challenge was in many ways what it remains today, which is moving towards universal coverage so that no American gets left behind. And also the challenge was and is keeping costs under control. And again, my 10 years in this business having been defined first by the Affordable Care Act, where I was pretty clear with my constituents that I thought it was going to substantially expand coverage, create better coverage, things like the elimination of the old tradition of insurance companies turning away people with pre-existing conditions, making sure that all insurance plans had some basic minimum level of coverage so that people weren't ambushed by terms that were on page 85 of their inadequate health care plan. I really do feel like we've made a lot of progress, but we obviously have a long way to go. And all three of us hear on a daily basis from our constituents about concerns around premiums, around escalating costs of pharmaceuticals, escalating costs of healthcare generally. So I'm going to stop talking right now because my objective is really to learn. One last thing I'll say is though the political discussion around healthcare is underwhelming to say the least, meaning it tends to sort of be a religious issue for the parties. I don't say this about a lot of topics, but my friends on the other side of the aisle got a little bit of a dose of reality in terms of how complicated this is and how important it is to people. And the political debate. We passed the Affordable Care Act, which of course is something that was passed by a Republican governor of Massachusetts. We were told it was a travesty and a failure, and that for 8 years we heard how very rapidly they were going to repeal it. And when the moment came to repeal it, to their credit, my Republican colleagues listened to their constituents who said, "Don't repeal it. There's things that we don't like about it, but the structure of the thing made sense." And so, lo and behold, after promising for 8 years not to repeal it, they didn't. So the reason that's a good thing is because that instilled a certain degree of realism in you've got three Democrats here on the other side, which hasn't stopped, sadly, some of the efforts to sabotage the Affordable Care Act. But we are at a point where I think, particularly on the other side of the elections, we'll be able to open a discussion about how can we try to move to a place where we can make progress on increasing coverage, on creating a better experience, on keeping costs low. So again, I'll end where I started, which is thank you for providing the three of us with what I'm sure will be some really interesting ideas. And with that, my friend, former member of the House of Representatives, now a member of the upper house, the United States Senate, and really a guy who's, though he comes from just north of here, spends a ton of time down here in Fairfield County and in Norwalk in particular. So welcome, Senator.
Thanks. Thank you, Jim. And sorry, everybody, for being a little late to the party here. I was actually up in New Haven meeting with some of the healthcare providers which have been dealing with this catastrophic contamination of this K2 drug that's been being sold on the New Haven Green over the last week. And so I was up there with a bunch of providers, and I apologize for being a little bit late, but I don't think there's much I can do to build on what Jim said. I guess I maybe am a little bit less optimistic than Jim is about the ability to try to suck some of the political venom out of this issue come next January, in large part because the president seems to every week come up with new and creative ways to try to destabilize the existing healthcare system, and it's kind of hard to figure out what the root causes are of his crusade to try to sabotage not just the Affordable Health Care Act, but the broader healthcare system, other than he's mad that the system has President Obama's signature on it, and that though he promised to repeal it, because, as Jim said, of popular backlash against repeal, he wasn't able to get it done. And I do think it's important for us to get together to talk about what is happening in Washington, because people are going to have a lot of questions as their premiums are going up and as choices get a little bit fuzzier, as protections start to winnow, and I think we all need to be able to explain why that's happening. And so maybe, I'll just sort of take the cue from Jim. I don't know if he ran through some of the things that have been happening, but they're important to talk about, because Bob is obviously dealing with how to protect Connecticut from these changes. First and foremost, we don't have an individual mandate anymore in this country, for all intents and purposes. We have a mandate, we don't have a penalty. And so, CBO says that's going to mean about 13 million people losing coverage, and likely those are mostly younger people and healthier people. And no insurance company yet really knows how to game that out, but there's no doubt that that's going to be a pretty big increase in cost. Most of that was priced into the premium increases last year, so the reason that you saw 25% proposed increases last year and 12% increases this year is because most of the insurance companies preloaded what they expected to be a flight out of the market of healthy people. But that's going to continue. That's going to continue. It's going to continue to drive prices up for those who are left in. Second, we've got these short-term plans that we're still trying to figure out what Connecticut can do and can't do. But there's no doubt there's going to be a bigger effort by this administration to try to push these short-term junk plans on people. Now, Connecticut passed the requirement that they all still comply with the minimum benefit requirements, but there are other consumer protections that are not guaranteed in Connecticut. For instance, the medical loss ratio provision does not apply to short-term plans sold in Connecticut, and the cost sharing requirements that you have a maximum out of pocket, that protection doesn't apply to short-term plans sold in Connecticut. The president also has made it clear that he wants the federal dollars that are being used for navigators and for folks to help sell these plans to push folks to the short-term plans. Now, I don't know that a lot of those folks are going to listen to the federal direction here in Connecticut, but the president's going to spend a lot of time during open enrollment just from using his bully pulpit, telling people you shouldn't go into the ACA plans, you should go to the short-term plans. We just got to be ready for that. We got to be ready for that when open enrollment opens up. And then lastly, this court case. So Texas v. United States essentially says that Congress cannot, under the United States Constitution, protect people with pre-existing conditions, at least in the way that it's done under the Affordable Care Act. Under normal circumstances, the administration defends every law from outside attack, even if they don't agree with it politically. And they have chosen, in this case, to side with the petitioners. That's why the Supreme Court fight, of which I have a vote, matters here, because this won't be the last attempt by this administration to try to use the court system to get done what they can't get done democratically. Even if this case fails, they're going to continue to use the court system to try to do an end around on a political process through Congress that can't get the law repealed, at least the majority of it, because people basically like it. And so one of the main reasons why I'm opposing Judge Kavanaugh is because I know that he was selected by Donald Trump. He was endorsed by the Heritage Foundation and by the Federalist Society because he will be a reliable vote to gut federal health care protections. And so we have to be ready for a Supreme Court that is going to be increasingly hostile to some of the things that we pass democratically. So that means that, politically, we need to let people know what the stakes are of this election. We need to explain to people why certain things are happening. We need to be ready for open enrollment because open enrollment is going to look a little different this year than it has in the past, given these other options. And then we need to work with Bob and his colleagues to figure out other ways that Connecticut can continue to try to adjust to this landscape. And so that's a lot. That's a lot to put on the plate here, but we wanted to make sure that we give you the best information and to get your feedback. So I'll stop there and sort of offer the table up to comments or questions from folks here.
And please, if you would, introduce yourself if you want to ask a question. We didn't have a chance to do that when we first started.
Somebody started.
Yeah.
I'm Chuck Eric. I'm the chair of psychiatry for WCHN. In terms of, presidents come and go, is there a long-term plan that the Democratic Party is attempting to put together to address universal health care, going forward, regardless of who's in power?
Well, let's first consent that that we are pretty darn close to universal health care today. You're talking about a very small percentage of the population that doesn't have it, largely residing in states that have refused to implement the federal law. But there is certainly this robust conversation happening within the party about what the future of the American healthcare system should look like 5 or 10 years down the line. I've been a part of that, and I'll share quickly what my thoughts are. But I have largely counseled my colleagues to focus on the here and now, because if we spend all of our time designing a healthcare system that we can implement once we get control of the House, the Senate, and the presidency, we may have lost the healthcare system that we have now because of the changes that the president is making and the continued desire of this Congress to unwind what we have. Remember, at the heart of that repeal bill is the end of Medicaid, right? It was sold as a repeal of the Affordable Care Act, but the most consequential provisions in it were the end to the Medicaid entitlement. And so if we get sort of caught talking about the long-term future of the system, Medicaid will be gone. So that's my only counsel. I have not signed on to Senator Sanders' single payer system, not because I wouldn't design a single payer system if I got to design something from scratch, but because I think it's much more realistic to create universal access to Medicare. That means allowing every individual to be able to buy a Medicare plan and every business to be able to make its employees eligible for Medicare. I think if you did that, there would be a pretty quick rush to Medicare, and ultimately you might end up in the sort of medium term in a single payer healthcare system, but it would happen through consumer choice rather than through prescription by government. And so I've introduced that bill, that concept I've introduced in the Senate with Senator Merkley and Gillibrand, Harris and Booker and a bunch of others. But I think it's probably better that we focus on the here and now. What do you think?
The only thing I would add to that is the answer to your question is no. There is no pre-baked plan that the Democratic Party has. And in fact, Chris alluded to the fact that even inside the party there is more tension than there needs to be, but still tension between a more Bernie Sanders-like position, which is let's go straight to single payer, which is not intellectually a bad idea. Medicare single payer to be a single payer. Lots of countries do single payer. Those of us in politics would say, oh man, the political lift, having lived through what the world looks like when you tell the American people that things are going to be different in healthcare, that's a big one. So no, there is no plan. Chris really, his plan, buy into Medicare is really attractive for a whole bunch of reasons. The one thing I would add to the debate though is that Medicare is a program that pretty much everybody loves, that also has some very serious long-term sustainability issues. So there's already, given the demographics of the country, a very substantial overhang liabilities that have not been funded by the Medicare system. I think under Chris's plan, that would be dealt with by pricing Medicare at an actuarially neutral way. But anyway, my point is that regardless of the provider model or the administrative model we go to, we are still left with this immensely difficult challenge of getting costs under control.
Doesn't have to be questions, comments too. Tell us what's going on.
Suggestions?
What are you guys working on?
Hi, I'm Erin. I'm with Open Doors here in Norwalk, and I just wanted to share a little bit more about how accessible healthcare really affects everyone in our community. I know you are very keyed in, and you've been such great supporters, but we have particularly vulnerable people that we're working with. So we work in coordination with really amazing local health partners, but we can't do it all on the local level. So to have support in the state and to have support from our elected officials makes a huge difference. So our clients, to have accessible healthcare means that these are families where people are able to keep their jobs, they're able to get their children the healthcare that they need, and they're less likely to return to shelter. They're more likely to stay stable in their homes. And we've also found, working with our local health partners, that the emergency room visits have dropped by 65% because people are able to get the care they need when they need it in the way that's most appropriate for them. And we're also a small group, we're a nonprofit, and many of our staff members are part-time. So for them to lose their health care, folks who are cooks, are night monitors, are really on the front lines doing work for people who really need it, for them to also lose their healthcare is a dangerous situation to be in. So we know that it makes a huge difference for people here, across the state, across the country, and we're glad that you pulled this all together and are trying to find solutions.
One of the most amazing statistics in our healthcare system over the past 6 years since the implementation of the Affordable Care Act is the astonishing decrease in personal bankruptcies. So personal bankruptcies have been cut in half in the United States since the implementation of the Affordable Care Act, and it's for one reason and one reason only. Prior to the Affordable Care Act, more than half of personal bankruptcies back then, 1.5 million a year, were caused by medical debt. It's not that there's no one that goes into bankruptcy today because of medical debt, but we have lopped 750,000 annual personal bankruptcies off of the court system because it happens very rarely today because of the accessibility of care.
Can you, it's Adele Gordon, can you talk a little bit about the Medicare and negotiated prices for pharmaceuticals? I mean, that, to me, if they could, that would reduce cost a little bit if they could negotiate. And is that a reality ever?
Take it.
Well, the history here, and maybe Chris can pick up on where we might go on this. The history here is pretty clear. Under the Bush administration, when Medicare was expanded to include the drug benefit, the big ugly negotiation, which happens, of course, around any public policy change of that magnitude, involved a commitment on the part of the administration not to use the Medicare purchasing power to negotiate prices, which is a bit odd because, of course, the VA does that, but that was the political calculus, and that is one of the reasons why the exact same drug costs significantly more here than it does just to our north in Canada or in other countries. It has the net effect, of course, of American consumers and American Medicare payees really subsidizing the budgets globally for these pharmaceutical companies. So that's the history of that, and certainly the notion of revisiting that and pushing back and allowing Medicare to negotiate hard is a political idea with a lot of momentum, but not one that is necessarily accepted by Republicans, and certainly not accepted by the pharmaceutical companies.
Yeah, it's unfortunately, at this point, a pretty partisan issue. So it is, there's scant Republican support for this idea. Which is interesting because Republicans spend a lot of time lecturing the country about running government like a business, and we push back on that idea because in many ways government is the antithesis of a business. We are involved in the services that can likely only be run through the joint exercise of government, but this is an example of a restriction on the government that you would never ever foist on a business, the inability to use your bulk purchasing power to try to drive down costs. So I don't think it happens until there's a pretty seismic shift in the political alignment in Washington. But I had a fascinating conversation years and years ago with a CEO of one of the big international drug companies, and it was just me and him in his office, nobody else. And I said to him, what would happen if we did this? Because you guys obviously, claimed that the sky would fall. And he said, well, listen, yeah, he's like, initially, obviously it'd be a shock to our, to our revenue, and we'd have to make a whole bunch of cuts. We'd probably cut advertising and marketing, and we'd cut some research and development too. He said, but honestly, over time, it would end the free rider syndrome. I would then be able to go to other buyers around the world and say, hey guys, sorry, I can't sell you this drug at a loss any longer because I'm not getting what I used to from the United States. And over time, because my leverage would dramatically increase overseas, and granted, still most of their sales are in the United States, I'd get back to the point that I used to be. He's like, maybe it'd take a decade, but I'd get there. And I just think at some point you got to pull the Band-Aid off because we're getting screwed. But I don't think it's happening anytime soon.
I'd like to, Craig, I just want to, you have your hand up, which
Oh,
is great.
sure.
So I wanted to have you talk a little bit about, Craig runs our
Yeah.
community health center here in town, and talk a little bit about what the ACA has meant for people who come in through your doors, and what kind of that means through the process, I guess, and how it's been working lately.
Sure. Again, I'm Craig Glover from Norwalk Community Health Center. So for us, for ACA, what it allowed was more people to access healthcare because our percentage of Medicaid patients increased during ACA. So there were more folks who had access to healthcare, which meant that there are less folks who are going to the emergency room or just not accessing care at all. So, I mean, it certainly has made a difference. As well as the exchange, there were some of our patients that were uninsured that were able to purchase plans on the exchange for insurance coverage as well. So as the government thinks about tinkering with the Medicaid program, you know, that becomes a big issue for us, for the people that we serve, because those folks who are now accessing care, they run the risk of being back and uninsured, which means they're back to lack of access to health care, they're back to the emergency room for primary care as well. Another thing I wanted to touch on, though, is while our healthcare system is under attack, and you know, from the president and the Republican Party trying to make changes, I think what we should be doing is trying to figure out what can we do to sort of maintain. And one of the things, this is something that came up in our office earlier this week that we were talking. There are some things that we can do, I think, legislatively that will increase access to services. So one of the challenges that we discovered is Medicare only pays for certain types of people, particularly in behavioral health, certain licenses. So if you're a licensed marriage and family counselor, or I'm getting the acronym wrong, but what is
So
it?
it's LMFT,
Yeah.
the licensed medical family, and LADC, the licensed alcohol and addiction counselors.
Yeah, those folks, when we hire those people to work with our patients, Medicare doesn't recognize those folks as providing a service. So that means that that's a service that we have, but when we see a Medicare patient, we can't provide that service. To me, that's a simple fix. You know, a legislative thing of going to CMS of saying, here are these folks, they have the credentials, the credential organizations are established. Why can't they be considered and as folks that can provide a service? So for us in our office, we have some of those folks. We can't connect them to our Medicare patients, so that's limiting access. There are other examples of things like that. So I think while we're trying to figure out what can we do while we're under attack for ACA, I think there's some other things we can do that can increase what we can provide right at the moment.
You know, we were, this was part of the conversation we were having in New Haven was around recovery coaches, which have, you know, been utilized really fantastically here in Connecticut. We're leading the way in terms of developing this model of early interactions with people in the throes of addiction, but they're not reimbursable. And so we have recovery coaches paid for by grants, paid for by, you know, just expenses lying around at, you know, acute care hospitals and health centers, you know, it's just another example of a place where the evidence tells us clearly that a healthcare service is necessary, and yet we have to scramble to find the dollars to frankly save the insurance company money.
Exactly.
So, you know, their reimbursement policies and Medicare's reimbursement policies seem to be 5 to 10 years behind the,
They're outdated.
the best evidence curve.
Hi, I'm Garen Mullen. I'm a volunteer on behalf of the Alzheimer's Association and the ambassador to Senator Murphy. And first, I just want to say thank you so much to Senator Murphy for his incredible support for the bills that we've had kind of up for discussion lately, the BOLD Act and the Pachita Act, which are really incredible in thinking about Alzheimer's care and about aging care and hospice training. Separate from that, just a comment and a thought from the younger voter base that I think a concern that is out there is the sustainability of healthcare and the rising costs, just thinking about those of us with aging parents and what that landscape is going to look like in the future, whether it's ACA or what this is going to look like. Secondly, I'm an assistant principal in a middle school, and we're seeing just an incredible rise in mental health issues for young kids. And, you know, Connecticut really struggles with having kids be able to access mental health care and have parents know what to do within their healthcare systems to be able to provide care for kids. And I know that you've been working diligently on that, but it's still a concern just from the school level.
Yeah, well, thank you for the great work that you guys do. If your ambassador was here, they'd say really nice things about you too. So there we go.
She's
Teed up.
here.
Teed up on the other side,
The
so.
segue was going to be, are we blessed? Because
We are
have
beyond blessed.
Two wonderful advocates for the Alzheimer's cause in Washington, and Congressman Himes, as well as Senator Murphy. So, yes, we appreciate your
Three.
strong.
I don't have an
We
ambassador.
Get Duff ambassador.
And in Hartford, most definitely, also.
I think one of the reasons that both Jim and I were very concerned about this giant tax cut bill that got passed is that it is almost wholly deficit financed, meaning we're just borrowing money in order to give tax cuts that accrue almost exclusively from a percentage basis to the very, very wealthy. Is that it's just exacerbating this sustainability crisis because we do draw upon the general fund to pay Medicare bills. We don't do that today for Social Security, but we'll have to soon. And so you are just making that crisis creep up on you even faster by saying that our priority is to give massive tax cuts to corporate America beyond what they even dreamed was possible under this administration, instead of shoring up these programs which help everybody across the country. And so we talk about the danger of this tax cut in healthcare terms often, because we know what it can mean ultimately for Medicare and Medicaid.
Could we elaborate a little bit on where it's just very on the issue of behavioral health care addiction? This is something that all three of us, I think, are dealing with on a daily basis, whether it's opioids, what we just saw up in New Haven, and of course, you really piqued my interest when you said you're seeing an increase in behavioral issues in the school. Can we get some color on what the causes are and what you see working and what's not working?
I'm not quite sure what the cause is directly. Maybe I'm actually also trained as a school counselor and did that work before I went into administration. And I think across the board, and not just in Connecticut, across the nation, we're seeing a real increase in anxiety in our young men and women. And I think that the triggers and the causes can be, probably variable in different areas. I think what I see most concerning in the schools is the lack of information out there for parents about what to do for their children. There's no guidebook for parents if their child is experiencing real mental health issues, real anxiety issues, and there's no playbook for the kids as well. So although we have some schools that are incredibly resourced, there are other schools that just have such limited and lack of resources. New Haven just laid off 20 school counselors, and these, I think buildings are really struggling with what to do, but from a public health care perspective, there has been so much verbal support around we need to get this done, but out there for the parents, especially for our young kids, maybe ages 9 to about 13, 14, before they're really in those teenage years where there's more groups and supports, there's no real place for the parents to go and for the kids to go. And whether the healthcare supporters are going to be able to provide services, and it's not just out of pocket, I think is a real concern for some of the parents around the state.
And I was reading a report 2 months ago or so, looking at the total dollar amount of money spent in urban schools versus more affluent suburban schools. And the narrative in Connecticut often is, well, we're sending all of this money to the cities and it's still not changing the reality for these kids. The idea is that there's this big, massive transfer of money from the rich suburbs into the urban schools, and it's not fixing any problems. And that's simply not the reality. On a per student basis, kids in Bridgeport, we are spending half as much money on them as we are, even given the state money that goes to Bridgeport, than is being spent on a kid that goes to school just 1 or 2 towns away. And much of that extra money is spent on all those support services that just aren't there in those elementary schools in Norwalk or Bridgeport that are there in Darien, are there in Greenwich. So yeah.
Do we have anybody here from the school-based health centers at all? Well, the reason I'm bringing it up is in Norwalk we have the Dr. Robert Appleby school-based health centers that are funded federally and state. And I sit on the school governance council at Norwalk High School, where I'm a parent there, and we had a health fair, and we had counselors there speaking and trying to talk to kids about their stress levels. And what we found, I'm just as a parent, and to learn a lot of this stuff as a legislator too, and that helps you in what we do, but the amount of stress that kids are under right now. And some of it is schoolwork, some of it is the parents are stressed because they're working 2-3 jobs, because they're not home as in traditional kind of family times that was once a long time ago. And so there's just a whole lot of stress going on right now, and part of what was done in the school-based health centers outside of the high schools was trying to put more mental health into at least the middle schools, if not the elementary schools, and trying to identify some of the stress and anxiety and mental health issues earlier on, rather than waiting until kids get to high school, because at some point it gets to be where you can't change that path, or it gets much more difficult to change that path, and then parents, like you said, really don't know what to do. They don't know the signs that are out there. So this is an area for, I think, all of us to continue to push on, because it's something that's not tangible until it's too late. And for all of it, I think whether you're state, federal, or local elected officials, we need to be doing a much better job of working in that arena, because we see it's not an issue that is waning. It's an area that is growing, and we need to fight that issue and address it.
Yeah.
Okay, yeah, I'd like to make a comment about this discussion. I think mental health care spending is going up dramatically. Pouring more money into mental health services, and I'm sorry, because I'm a psychiatrist, and obviously my bread and butter depends on mental health services. But the problem has to do with our society. The problem has to do with the disparities between the haves and the have-nots. And those who have are a smaller number of people in our society, and the have-nots are a growing number. And so the expectations on kids are only increasing to become one of the haves, because those opportunities are disappearing. And so the demands being made on them and for them to succeed in life are really quite narrow. And that's what's leading to a lot of anxiety. And I see this I have children as well. I see this from my kids and what the expectations are set upon them in school and what society is doing. And it's clear, research has demonstrated, when there is a relative disparity in income, as that disparity grows, you see a greater number of issues with anxiety and depression. It's not absolute numbers, it's relative changes. So that, at the risk of sounding like a socialist, there needs to be a push to try and decrease that income disparity between the haves and the have-nots, and create opportunities for more individuals to have reasonable jobs, so that they don't have to work 2 or 3 jobs, and they don't have to put pressure on their kids that this is the only avenue to success. And if you don't become successful through this avenue, then you're really going to struggle. And that's really where the focus needs to be in terms of government, not increasing mental health services, because that's already created the problem is already there. And we've already demonstrated, suicide rates are higher, the opiate crisis is increasing, and we're pouring more and more money in mental health services, and the issues are not being successfully addressed. So I really think it's a public health, we need to take a public health and societal look at how we deal with this problem, rather than just pouring money in mental health services. That's my 2 cents.
Yeah, it's not a coincidence that the schools that have the higher acuity of kids with serious mental illness or trauma are in the poorest neighborhoods, right? Just like I always say, it's not a coincidence that the lowest performing schools are in the most violent neighborhoods. All of this stuff works together. Yeah.
So my name is Karen Gottlieb. I live in America's Free Clinics. And I just want to get back to something Adele asked about, which is pharmaceuticals and something else. We take care of patients who have no health insurance. We don't qualify for health insurance. We're going into our 25th year in Norwalk. And pharmaceuticals are a very big problem for our patients. Undocumented constitute a significant percentage of our patients. They don't qualify for some of the free routes for getting medications. We don't qualify as a network of free clinics for 340B pricing, which the community health centers do. And so, we're paying a much higher rate for medications when we have to purchase it. So pharmaceuticals, whether it's insulin for our patients right now, which, we've always been put into an insulin crisis, it's a problem. And I think the other issue I think that we're seeing is the increase in complexity of patients and the increase in chronic diseases. Our patients are, seldom do we see one disease at a time. Everybody's diabetic, hypertensive, obese. And that constitution of illnesses doesn't respond to pills. It responds to lifestyle change, it responds to nutritional counseling, it responds to a lot of other things, but pills is not a quick cure. And I just think that if we could get a handle on some approach that was successful, medicine is one part of it, but there's other things that have to go concurrently with that to make those changes to be successful in treating those illnesses.
You mean the integrated approach?
Health coaching, nutritional
Yes.
counseling, diabetes education. We're working on a program here in town on diabetes prevention. There are a lot of things out there, but it really takes a community coming together to make that happen.
Well, as you know, the Obama administration had this very aggressive plan to transfer all of our fee-for-service payments to quality-based payments, and I get how difficult that is because not everybody can agree on what the metrics are to apply that system to, but they were, they hit their marks by the end of 2016, and then Tom Price got selected to be Secretary of HHS, who was the primary opponent of quality-based reimbursements in the House of Representatives. And so once he got to HHS, he just pulled apart all of the work that had been done to try to build reimbursement systems that that support that kind of holistic health work. The interesting thing about Azar, I think Azar has been pretty terrible, but he's not terrible on this. He actually has tried to restart some of the value-based payment work that Price unwound, but it's kind of tough to restart it from scratch again. But I think until you have a payment system that really gives you more money for healthier people, rather than what the system continues to do today, give you more money for sicker people. It's hard for systems to put to pay the people who do a lot of that, nutritional work and lifestyle coaching. Again, positions that are not reimbursed. Today the system still doesn't reimburse for most of those activities.
Are there models out there, maybe I should know this, but are there models out there that are really demonstrating success in things like nutritional counseling and healthy living and good primary care that reduce type 2 diabetes? What should we be aware of that's working? Because one of the things the federal government at any time can do is sort of act as a purveyor of best practices.
Is that it?
We have a health coaching program in our Danbury clinic that's funded by our good friends Barry and Mohan. And it is based upon a program out of the University of California, San Francisco, their Centers for Primary Care Excellence. And it basically shows that if you work with somebody who is a significant diabetic, hypertensive, or high cholesterol patient, there's a whole format set up that it's a 12-month program. And you can actually reduce the rates of, reduce the levels of A1Cs, reduce blood pressure, reduce cholesterol levels. But it takes a lot of work. It's teaching, empowering, coaching, encouraging, giving the confidence to a patient to make the change. It's not an easy fix. It's a really big challenge, but they have a model that actually works quite nicely.
I was just saying, my name's Eileen Cardos, and I work here in our population health department with Nicole. We work in our community care team here at the hospital in a program that follows frequent visitors to our emergency room. And we've definitely kind of adopted the mentality that if we are really going to reduce our healthcare costs, it's really going to come down to kind of changing the definition of health from being, you know, the absence of medical symptoms and disease to really incorporating health to address all of our social determinants. And so basically the work that we do is really formulating community partnerships and, you know, increasing communication between departments in the hospital. And as we come across these really socially complex patients, medically complex patients, it's not so much about everything having to do with addressing their medical symptoms, but it's about, you know, maybe stabilizing them socially. And we have really ended up reducing the amount of patients who are coming to our emergency room or coming up on our radar who are such high cost patients. And you know, what it costs to have an individual who may be struggling with an alcohol misuse diagnosis and is also homeless, what that might cost the Medicaid system coming to the emergency room 110 times a year is way less expensive to work to get that patient housing, to get them into a program. And, you know, we've really worked to reduce costs on our end through those types of programs. We've seen them to be successful.
Congressman, if I can add to your question and to follow up on what Karen said, there are lots of models out there. I mean, you can go out and, you know, Google them. There are websites full of different evidence-based models, but, you know, we come back to sort of the theme of the day is we can do all those things, but if there isn't funding that supports it, then we can't implement those. You know, Karen talked about her program in Danbury that's funded by another organization, but without that funding, that program goes away. So I mean, that's really the challenge is how do we pay for this?
No, I think the idea of what is healthcare, right? I mean, is a fundamental question that, you know, we're not equipped to really deal with at this point, right? I mean, why are Medicare dollars not eligible for food, right? Mm-hmm. When the most important thing, you know, to some people to maintain their health is access to healthy food, and so we'll pay for all of the consequences of not getting the healthy meal, but which can be in the millions of dollars per person, but we won't pay for the, you know, couple bucks a day it might cost to get that person access to food. It doesn't make sense, but to uncompartmentalize nutrition policy from healthcare policy, from housing policy, right?
From social service policy,
right.
You know, that same elderly person is isolated. Bringing Meals on Wheels covers so many bases,
Mm-hmm.
you know, and it doesn't cost anything. It costs much.
Yeah.
My name is Kat Hunter. I'm a traveling case manager, and I'm not from Connecticut. I'm from Florida. And you're talking about a model. If you get an opportunity, look at Pinellas County insurance. I'm from Pinellas County, and I've been a nurse there for way too many years. But we had the same issue. We were losing money like crazy, and the people we needed to focus on weren't getting the health care. So we started off with physicians who are volunteering their time in 3 clinics throughout Pinellas County. We would give you a bus token to get to and from your doctor's appointment. You don't get the bus, you don't come. That's it. You got to be responsible for your health care. The majority of the people were showing up. You know, we would give out 25,000 bus tokens and 24,000 people would show up. So we see right there that they want to be better. They want to be healthy. They want to get what they need. Then we instituted a sweat equity. Who's going to fund this? Those people that needed the services were funding it. Sweat equity and helping the elderly rebuild their homes, paint their homes. Anybody in need. We had people in soup kitchens. I mean, we have people everywhere, and it's mandatory that you put in 4 hours a week in sweat equity, and they're showing up. And we've been working on this for the last 12 years, and I can say the last 6 years is when we started it's an HMO, it's a Pinellas County Insurance. You don't have to be a resident of Pinellas County. We don't look for your address. We don't send you bills. Just come on in. And we've noticed there's a huge decline in admissions. Huge decline. We started seeing healthier people. Pinellas County, it's Florida. We have a huge population of warm, homeless people. And so we need to put them to work. And we're finding that the more responsibility they had, the more responsible they became. And I just love being from there. But yeah, that's a good example. And Representative Kathleen Peters, I've worked with her for the last 10 years. And she's getting it. She's getting it done.
Yeah, well, I mean, it speaks to the fact that there are a lot of models, and that is right. I mean, the federal government should be in the business of taking the models that work and then helping people expand them. So I think we're getting to the point where we got to wrap up. Anybody have anything for the good of the order? All right. Well, listen.
I'd like to say thank you.
Yeah.
I appreciate you coming down to the community level and listening to what we have to say about ACA changes and how it's impacting us and all the people that we serve. So thank you for that.
Well, like we said, I mean, we don't yet know the effects of all of this, and so we're just going to count on you, especially as we get into open enrollment, to let both of us know what's going on so that we can adjust and we can articulate, the reality for our colleagues. So we'll continue to do it. All right. Have a great weekend, everybody. Thanks. Take care.